Generally what we do is we'll pick a time of the year, usually 2 or 3 times a year for a week, and everybody that comes in that week gets it.
Is that the same in Danish concept?
Oh yeah, if you do it then you do that.
That's also...
And it turns out to be relatively random. If you actually look at the numbers, it sort of reflects the random distribution of practice.
Yeah. But I wonder one thing, patient satisfaction is not the same as measuring a good therapeutic relationship.
No.
It's two different things.
The Danish survey that we do is not only on satisfaction, it's also the perception of quality and the perception of your relationship with the doctor. So it's broader than just where you're happy.
Yeah, but is it therapeutic?
Is it assessment of the therapeutic relationship?
At least some of the questions would be.
My point is something we have to consider about types of simulation.
But also an instrument would probably be, if you have those patients, when they change, then maybe discuss with the doctor who they chose. So what are your experience about? What's your experience with this patient? Or maybe have a focus group with some of the patients who changed within the practice or whatever.
About 20 years ago we had, 5 years ago we had a conflict with the health insurance. So we went out and contracts with people. So we did one day survey in the waiting room, asking the patient, how much do you think the normal is doctors? What do you think would be fair? And they all thought we paid more money than we actually did, and they all like to give us a bit.
Really?
Well, not out of their own target, probably.
Yeah, I was going to say that. That's
There's
interesting.
something about this thing, what is your patient attitude?
Yeah. Interesting.
And in Denmark, it's the rate of wages in general practice is actually higher than it usually is in the US at least.
Yes, I know. 200,000 I was told.
Yeah.
Yes.
A little less than that.
It's something in the process, conversation process, communication, which I'm thinking without getting any further without it brought up the 15-minute hour and the way should we try to look, listen to things. These sort of important steps.
Yeah, I mean, I won't.
Should we take leave the subject go on, or do I want to continue?
Well, for example, we know that there's some very simple things that can have a great effect. There have been some studies in the surgical literature where if a surgeon doing hospital rounds on post-operative patients sits down to talk to the patient compared to stands up to talk to the patient actually perceives that the surgeon was there twice as long sitting, even though they were only there half as long in actuality in terms of the study design. So that's a technique you can actually teach people. It's simple. I actually teach residents when we're doing hospital rounds. Sit up.
And then after that comes the, what you call it, hygiene team.
Hand washing.
So you can't sit down, you have to stand up, and you have to dress like this and that, and stand up, you can't touch anything.
I didn't know there was any hygiene problems with sitting.
We started by discussing EQuiP, which was actually developed as part of EQuiP work. And we said that it's a very good instrument. It's translated into several languages, and it's a proxy measure of the therapeutic relationship. And there's a short version that concentrates actually on the items that have to do with the therapeutic relationship. And there's comparability across them, and there's people who are doing research on it, right? Yeah. Then
Sorry, because I don't.
EQuiP.
EQuiP.
PEP.
But give me an example of the
questions. Oh,
yeah, the questions.
very well.
For instance, do you feel involved into the decisions in relation to your health with your GP?
Okay, yeah.
Then the other instrument is good for teaching about therapeutic relationship. What we do in Copenhagen at the university department, we look at the consultation process with last year students. They take a video and then they analyze it according to a 9-step process, and that's for learning about techniques for getting a good relationship. It would be a very heavy instrument to measure it, But the last point there is that if you have used your time well, at the end you have a little time to discuss personal things with the patient. So then you have used your time well, and you can connect with the patient also on another level, except just for the illness. And then the third one was...
Wait, can you tell us a bit more about
Yeah.
the video, the 9-step analysis? Just give us an example of that. Does anyone know this?
Well, it starts by saying what is the problem today, and that the patient defines the problem, and then the doctor lets the patient talk about the problem until the patient is ready. I mean, this is good old stuff. Pendleton and everybody else has done it, but we use it as a standard instrument for teaching. And you don't stop the patient until they stop themselves. And then you start prodding, and then you make an agreement on what you're going to discuss. And and you involve the patient in the decision making about what shall be done about this problem.
Yeah. Good old Pendleton.
Yes. And then the third one is continuity measure that you actually could get from statistics. How often do certain patients visit a certain doctor? Is there a personal continuity in the relationship? And this again has all kinds of confounders, like what kind of healthcare system it is, and can the patient select another doctor just like that, like in France? And I mean, it presumes that the patient has an opportunity of selecting his or her doctor. But that would be a statistical measure that you actually could get from the patient records.
It's probably worth saying George Freeman, as part of another bit of this Kingston project, did a whole summary of continuity of care along with Jane Hughes. Sorry, George Freeman from the UK. So we looked at the quality of the therapeutic relationship, and we were told to leave out continuity of care, simply because George was doing it in a lot of detail. But yeah, and he found lots of different statistical measures of which are all, as you say, very much tied to different healthcare systems. So I'll give this back to you.
Are you ready on the large table? You've nominated Gordon again. It's always the fourth guy.
Can I just read them out then?
Only if you'd like to prepare.
I think what we have to do is just to read them all out, I'm afraid.
How many have you got?
Not too many.
What are you doing with this?
Videos with checklists, we read that, but it's important that you have a checklist. It's not a gut feeling by the person who's watching the video. They have to have the checklist to work with.
Sorry, can I provocatively challenge? Is this really how you wanted it? You would personally like to be assessed with a video with a checklist? Yeah.
I don't use it. Who is it? You use it.
Well, it's trained. It is used in our training program.
Do you want to be assessed in that way?
Yeah, I think I would.
Okay.
I also do it with my trainee. I also show my consultations, and we get feedback from the trainee. And we get nice discussions about it, not always with a checklist, but more on the things that I want to be asked about.
Right.
But it's very useful, yeah.
Okay, great.
We've had two tables. You both use videos in teaching.
Yeah.
Videos with checklists in teaching.
Another one is telephone questionnaires to patients. Practice assessment by the EQuiP. 360-degree assessments.
Oh, tell us a bit more about them, though.
Who does that?
We don't just want a list.
Yeah, who does that?
360-degree.
You use it.
Well, some discussion on that.
We were using it as not necessarily how I would like to be assessed, but it is used in 3 provinces in Canada, in Alberta, in Saskatchewan, and in Manitoba. And what they do is in Alberta, they're most far developed with that, have a separate company that selects a sample of everybody's patients and sends a questionnaire to those patients, and then anonymously analyzes the questionnaire and sends it back privately to the family physician. And certain very serious outliers, I think, still go to a committee at the college for consideration, but not for any pejorative type of responsiveness, but rather to, as a safety net, to help address those issues.
How many patients does it go to?
I think 18 patients in each practice, something, a random sample in everybody's practices. I don't know how many there are.
And what do they ask?
They ask general satisfaction about how much time you wait and how satisfied you are, and some open questions. And the questionnaire is on the web, and you can see it there.
And how many
It's not
relationships?
transparently reported, it's privately and confidentially reported.
So how many of the questions, as Iona says, how many are actually about the relationship?
I don't know to answer that question. I just know that there are some relationship questions in there which address issues like general satisfaction with the relationship.
Okay.
There is also on top of that peer assessments that's done in Alberta, which complements that. So your colleagues are asked to feed back in some kind of a non-projective, non-judgmental way, some kind of feedback, which I think can be very challenging in some situations, especially where there's younger, older physicians and hierarchical relationships and ability to actually work out who said what when there are only 5 people working there. So there are problems with that. And then there are other means within the 360 of self-reflection and asking people to respond to your self-reflection, which occurs in that process. But many people have written PhDs on the challenges of 360, so it's just out there because some are using it. I'm not sure I'd like to go through that process.
It wasn't much else. The annual patient survey, which I believe you do in the UK, one or two thought that maybe looking at doctors' lists and what the turnover is with that doctor. If the turnover is very high, it may reflect something. I'm not sure what, but it may reflect something. And finally, quality complaints box in the clinics or even on the internet, which our Canadian colleagues said they have and they don't like and can even be dangerous.
Well, we have Paul Hodgkin's thing there. What's it called, Trish?
I'm trying to think.
Is it, it's like Amazon.com, but it's for your, but it's very uncommercial, so it's nice and nice. Patient opinion, that's right. So yes, it accumulates. I think there's more stuff about hospital experiences, but it's a bit like TripAdvisor sort of thing. You never know who you're dealing with. Okay, so let's get all the stuff on the table, and then let's have a more general discussion about whether we feel we're not exactly breaking new ground yet. So I'm hoping there's going to be some really broken ground over here.